Hi everyone, thanks for listening to all my presentations. Today I'll be talking about Mirtazapine. Mirtazapine could come under different brand names like Remeron, SolTab, Apple Mirtazapine, Auro Mirtazapine, DR.BEN'S, JAMP and SANDOZ Mirtazapine. Mirtazapine belongs to the class of medications known as antidepressant, and to be specific, it is an atypical antidepressant, just like bupropion. It's also an alpha-2 antagonist. Uses: we can use mirtazapine to treat headache, and in chronic tension-type headache, could be used for prophylaxis. In unipolar major depressive disorder, mirtazapine will be helpful, and also in panic disorder. Forms: mirtazapine could appear as tablets, and in that case, we're going to find Remeron 5, 30, or 45 milligram, or generic 7.5, 15, 30, or 45 milligram. Could also be in form of disintegrating tablets per oral, that is given sublingual, as Remeron SolTab 15, 30, or 45 milligram, generic 15, 30, or 45 milligram. Adverse reaction: when mirtazapine is taken, there's likelihood of drowsiness, increased weight, hyperlipidemia, constipation, vertigo, twitching, nausea or vomiting, anorexia, urinary tract infection. The list goes on to include orthostatic hypotension, flu-like symptoms, increased acne vulgaris, akathisia, angina pectoris, angle closure glaucoma, aphasia, worsening asthma. Also, it could bring about cystitis, epistaxis, euphoria, eye pain, fever, goiter, gout, gingival bleeding, heavy menses, or hypothyroidism. Included on adverse reactions will be hyponatremia, hyperacusis, impotency, ventricular failure, prolonged QT syndrome. With prolonged QT, if it is not properly handled, it can progress to trazodone. And if that is not treated on time, it can progress to monomorphic ventricular tachycardia. And without correction, that will go down the hill to polymorphic ventricular tachycardia. Without intervention, we can then end up with ventricular fibrillation. If there's no immediate defibrillation, then we'll get into asystole. Without advanced cardiac life support instituted immediately, without code blue being called, there will be death. Pulmonary embolism, rhabdomyolysis, and seizures. Pancytopenia, toxic epidermal necrolysis, or Stevens-Johnson syndrome. Contraindications: we cannot use mirtazapine if there is hypersensitivity to mirtazapine or any of the components of the formulation. And also, we cannot use it with monoamine oxidase inhibitors, or at least we have to stop monoamine oxidase inhibitor for 14 days before we can use mirtazapine. We don't use mirtazapine with linezolid or Medlin Blue intravenously concurrently. 1. High risk of suicide in adolescents is a big sign that we need to be careful. When someone is on mirtazapine, we have to keep an eye on suicidal behaviors. Therefore, We must monitor closely for suicidal ideations and behaviors. Part of the warning includes not only keeping an eye on young people and adolescents where they are on mirtazapine, actually, indeed, in all patients taking any antidepressants. Not FDA approved for using children. No, for obvious reasons, right? Smallest therapeutic dose should be used at any time. It is only when we're not winning that we can then increase the dose gradually. We have to educate family members or all caregivers, respite homes or group homes, to keep an eye on anyone taking this medication for suicidal ideations and behaviors. There's likelihood of severe anticholinergic effects. Akathisia is going to appear in the first few weeks. If that is the case, please decrease the dose of mirtazapine, with the expectation that we may run into prolonged QT syndrome. Like I've explained, just about 2 minutes ago. You can rewind and get a full explanation as per prolonged QT. I don't need to waste time going over that right now. So with that tendency, we should have EKG done. Pancytopenia, if that is the problem we are faced with, please discontinue this medication. But we have to do that responsibly also. Central nervous system depression, if that is the problem, so the individual must not operate machines. No forklift, no flying plane, no working as a captain on the cruise, not driving those kids to the school now, not on public transit as a driver. Dizziness, increased bone fractures, increased cholesterol and triglycerides, increased glaucoma, or orthostatic hypertension. Serotonin syndrome can come up, and that will lead to agitation, hallucination, delirium, coma, tachycardia, labile blood pressure. The meaning of that is that the blood pressure will be fluctuating between hypertension and hypotension. Also part of serotonin syndrome will include diaphoresis, tremor, rigidity, myoclonus, nausea, vomiting, and diarrhea, and of course seizures. We are not done as per warnings, because individuals on this medication can gain weight. So why do we need to warn ourselves? If the patient will like to shed weight, of course, that's the advice we give to many patients, right? Shed weight. And we place this patient on mirtazapine without explaining to them that they can gain weight. Man, you can get sued. It could precipitate mania. Of course, when there is depression and you pick mirtazapine and the individual gets out of depression, then it becomes euphoric and becomes grandiose, and that is a mania, right? It's not good in renal or hepatic failure. We have to exercise caution in anyone with seizure disorder. And this is a very great warning also. Please don't discontinue this medication abruptly. No cold turkey here, please. Then what are we going to do? We taper off slowly. And I will need to list the extrapyramidal side effects that we might be faced with, like acute dystonia, akathisia, Parkinsonism, and tardive dyskinesia. Drug-drug interaction. I will leave that to the judgment of your pharmacist because the list is pretty long. You can also contact the clinical pharmacologist or better still, a psychiatrist. Monitoring. We have to monitor for signs of agranulocytosis and also monitor for signs of renal failure, having our renal function test done. Hepatic failure with liver function test done. We have to watch out for serotonin syndrome. You can rewind and get the list of signs and symptoms of serotonin syndrome: hyperlipidemia, panic attack, and weight gain. So we have to monitor all this. Don't do complete lipid profile, and of course question as per panic attack, and of course have your weighing scale to monitor for the weight gain. Mechanism of action. Mirtazapine is tetracyclic antidepressant, not tricyclic. It's tetracyclic, and is even an atypical antidepressant. It has a central presynaptic alpha-2 adrenergic antagonist effect, and that will lead to high level of norepinephrine and serotonin. It has antagonistic effect of H52 and H53 and histamine receptors. That's pretty good, right? It also antagonizes alpha-1 adrenergic and muscarinic receptors. So mirtazapine is a very good medication with broad spectrum. Examples of situations where and when we can use mirtazapine are the following. Headache. Can give mirtazapine 15 mg per hour once daily at hour of sleep. May increase to 30 mg after 1 week. In major depression, we can give mirtazapine at 15 mg per hour once daily at hour of sleep and increase by 15 mg every 2 weeks if the patient could tolerate it. The maximum dose here is 45 mg per day. In panic disorder, we can use mirtazapine just like the way I have stated under major depression. Don't discontinue mirtazapine suddenly, please. I have reiterated that here right now. We have to switch to other antidepressant very gradually. But if monoamine oxidase inhibitor is involved, there must be 14 days between the new drugs and the stoppage of mirtazapine. Either if you are using another drug and you want to, if you are using monoamine oxidase inhibitor and now you want to use mirtazapine, let there be 14 days. Or you've been using mirtazapine before and you want to switch over to monoamine oxidase inhibitors, let there be 14 days. In geriatric patients, that is in grandpas and grandmas, please don't give them high dosage. We have to start low. For example, you can give 7.5 mg once daily at hour of sleep. If we must increase that dosage, we'll make appropriate consultation with the psychiatrist or your pharmacist or clinical pharmacologist, depending on what is available and the protocol as your center or jurisdiction. With that, I've come to the end of this presentation as per mirtazapine. Please subscribe to my channel so that you can go through all presentations here. For example, this is mirtazapine, atypical antidepressant, right? I have a full list of all antidepressants fully classified already published here. And I've also represented selective serotonin reuptake inhibitors with Zoloft, already published. Tricyclic antidepressant have been fully represented with nortriptyline, being fully published. So you can get all these things here, and when you subscribe, you'll be able to get all other new presentations immediately they are published. I appreciate, share this presentation with your friends and your family members that are taking these medications. And you are free to leave your comments. Thank you.